this cardiac condition that's called myocarditis, inflammation of the heart, can be potentially serious. Thankfully, at least the last time I looked at this data, the total number of cases in the United States was relatively small, maybe on the order of about 700 to 800. Now, it's been a while since I've looked at that data, so I would stand corrected if that's changed, but it's a very small proportion of the overall young population that was vaccinated. And a clear phenotype emerged as to who was at risk, and it was the teenage young man as opposed to the teenage young woman. And so much of this in our cardiac field, we've had multiple papers published in this area. We have a feel for where this is coming from. We feel that the myocarditis that is induced by the vaccine is an example of what would happen if that child was exposed to SARS-CoV-2, but on a much smaller scale. So in other words, if a child that wasn't vaccinated had that immune predisposition to developing myocarditis that was unmasked by vaccination, in an unvaccinated status, the general consensus in the cardiac community now is that the expression of disease at the heart level would be much more severe. And I've cared for multiple patients with SARS-CoV-2 myocarditis and have seen the outcomes of that type of direct infection of heart tissue, and it can be scary and very dangerous. Thankfully, we haven't seen the same phenotype, and certainly you could speak to this at Cook's in terms of whether your cardiac group has seen really serious outcomes from post-vaccination induced myocarditis.
We've had minimal, there could have been one that was more serious. We've had a handful that were very not serious, kind of an overnight admission, ibuprofen, go home the next day sort of thing. We've had plenty of children with myocarditis from SARS-CoV-2 infection on the ventilator, on ECMO, which is the heart-lung bypass machine. We've had terrible heart disease from the infection itself, a tiny bit from the vaccine. My understanding is that the risk for the teenagers and 20 and 30-year-old men from the messenger RNA vaccines is in the ballpark of 1 in 10 or 15,000 doses, within a log of that, in that range.
Yeah, and I'll add a little bit. As a neurologist, even in the monologues, there was the questions about Bell's palsy or the nerves being affected. The big picture is the body does not like inflammation. And whenever you take a vaccine, you can induce a controlled inflammation. Whenever you get COVID, it's an uncontrolled inflammation. And so, you may have symptoms. The question is, how severe will your symptoms be if you don't have it under control? And that really, is the point that we try to talk to patients about, right? This is a discussion that you have to have with your physician to understand the risks, the symptoms that may come along, so that whenever if you happen to have them, you have a plan, you understand kind of what's coming if you develop them. But it's in a controlled situation. And so this goes to a lot of the neurological issues that have also happened. So this virus attacks all types of tissues in the body. And with the part of what the vaccine does is kind of cause some inflammation. And so, this is just something that we're dealing with.
Thank you for that. Quint, and then I saw two hands going this way.
Kind of on the same note as the variants question earlier, the two big variants were Delta and Omicron, but there are a lot of Greek letters and variants in between. What made Delta and Omicron more prevalent than the variants that were in between?
Not sure. First answer, I don't know that anyone really knows for sure. There are all the other variants. It's the alpha, beta, gamma, delta. I used to know the Greek alphabet. I don't know it anymore. And they skipped a couple of letters because they didn't want to irritate some people with similar names. The delta variant was, in my mind and in my clinical experience and probably in what you all saw, delta variant was awful. The Omicron variant, which we just got over in January, was lots more disease, but not necessarily so much of it for a pediatric hospital required ventilators and life support. We certainly had some, but proportionally that was a little bit less. There are all kinds of scientific ways to look at transmissibility and how the virus multiplies and how it is shed and how much you need to be exposed to. But I have not gotten a good answer as to why those two were worse. I'm just hoping we're nearing the end of the alphabet and that's that. That's enough of that. But I really don't have a good answer for you about why they were worse.
So one important clue, we've seen what we call the teleologic tree of evolution of this virus is, and nothing is linear in the sense that it's one strand turning into another strand, turning into another strain, I should say. So it's actually, think of it as a tree with many different branches. And it's all about competitive pressure in evolutionary biology. And it's all about what's present now in the engine is what's going to compete globally against each other and become a dominant strain. And the vast majority of this is really just viral entry. The ability of a virus to get into the first contact cells. And the moment it does that, and that's through the spike protein that we talked about, it's how quickly can it evade the immune response in your immune system, your innate immunity. And so if a virus has a mutation that allows for those two things to occur, which is entry and then escape, it's going to dominate. It's going to absolutely dominate, and that's exactly what's happened with each of these variants that have become the global, permissive variants that have led to a lot of disease and illness.
Okay, thank you for those answers. Our hands this way, here, and then travel. I'm literally traveling in a line, so right here. Thank you.
I don't think I could have ever. I had come out of my fellowship training within 3 years of whenever this happened, and there is nothing in med school, through my residency to my fellowship that would have helped me predict that this would have happened. It just came out of nowhere, and it was really daunting whenever you saw the things that were happening in Italy, and then New York was getting ready. And then you saw New York getting overtaken, and we started getting all this literature. And so we start kind of trying to set up our ICU. And so the one thing that I'll say is, in medical school, the one thing that we do learn is medicine and science. And so my training did prepare me to be able to take that information, whatever they were giving to us, for us to say, because we know that it's coming, how are we going to change our guidelines? How are we going to set up? And so I think there was that moment of feeling overwhelmed, but also that second part that you learn, which is you need to get to work. And, for our group, even though we're primarily neuro ICU, we knew that we were going to be taking care of very sick lung patients, and so you just kind of look back to all your training and say, okay, so we have to redo lungs, and everybody needs to be sharp on it, and what's the data for the steroids, what's the data for this, and we're kind of all trying to mine through it and get protocols ready. So I think completely unprepared, kind of overtaken by everything that happened, but ready and trying to get prepared for what was coming.
I would say go ahead.
Oh, I was just going to say I would never have dreamed this. I did see the movie Outbreak and Contagion. But, and just like in that movie, both of them, they were scientists working, right, to get a cure, and that's what happened. But I agree that the medical professionals have really shared information in that initial phase of how to best treat those patients in the hospital. My daughter-in-law is a nurse at one of the hospitals in Rockwall, and she would tell me like, oh yeah, we've learned this today, you know, prone the patient when they're on the ventilator. So the medical people were sharing information, working collaboratively. What's the best way to help this person get off of this ventilator? And that's something I admire about what has happened with the community.
One of the things that you're asking about, did we ever see this coming and were we prepared, and those questions, you can think in your mind, you know, if this happens, here's what we're going to have to do, and work out those thought processes about oxygen and ventilators. And when we were having meetings, the command center at Cook opened March the 15th, and we were in meetings all the time, thinking it's coming, here we go. They're having trouble in Italy, they're having trouble in New York. And the day that we had our ER emergency room physician call the ICU physician and said, I've got a kid down here with COVID and he needs to come to the ICU. We had been meeting for about a week or two, and the intensivist looked at me. We were standing in the ICU. He looked at me and he said, we're not ready. And I said, yes, we're ready. We've been talking about this for 2 weeks. And at that point, a team of about 12 or 15 of us said, okay, where is the mother going to stand when she comes up with the child? Because she's probably contagious. Is she going to go in the room or is she going to stand out here? What if she needs to go to the bathroom? What about the child? How are we going to get the child from the stretcher to the hospital bed in the ICU? Is that going to be in the hallway or out in the ICU? What are we going to do with these sheets on the emergency room bed? On. And we sat there for an hour and a half, and we did every single one of those details. And that, I think, to answer your question, is something that until you're in the heat of the moment, those aren't those little bitty things, you know, that you think of. And I thought that's a very prominent memory in my mind of when this started.
Thank you for those answers. So hands going this way, right here in the green. Yeah, is your shirt green? I'm sorry. Oh, I'm sorry. You.
The question is, does the vaccine have any impact on fertility?
Here is how I answer that question. My 27-year-old daughter has been married for 2 years. I made her get the vaccine, and she better give me some grandchildren someday. Soon. There is no evidence that the vaccine diminishes fertility. There are, I believe, 300 or 400 million doses have been given thus far. There's no drop in the birth rate in this country. What we do know is pregnant women who are infected with SARS-CoV-2 during the pregnancy have more fetal loss and worse outcomes. So we strongly recommend it for women of childbearing age. We also recommend it for women who are pregnant to give them better outcomes with their pregnancy. So I have zero concerns about fertility changes with the vaccine.
Okay, there was a hand right next to you.
I was wondering if you guys have any insight into how changes in land use and agriculture have led to the increasing more zoonotic diseases like the swine flu, Ebola, and now COVID. Just looking at this perspective as scientists on that.
Yeah, I'm so glad you asked that question. It's really key, and for this group to reflect on this is important, and it's important for us to promote this conversation in our communities. There's absolutely no doubt, clear scientific evidence that zoonotic diseases through closer and closer proximity between the wild and the developed world is leading to high risk of what we call viral and bacterial and fungal hot zones. Transmission between a infectious bearing host organism, a secondary organism, and then finally the human species is more and more likely something we're going to encounter. And so the challenge is, what can we do about it? We have an ongoing, we have ongoing population growth. There's a need for resources, food in particular. And so this is really a programmatic challenge at an international level between all countries. And how we decide to move this forward is crucial. So a couple of thoughts. Number one, if we can't commit to all the principles that would probably put a bit of a buffer zone between zoonotic diseases and the human species, then we have to start thinking about how we rapidly identify where those zones are. And so this all comes down then to the question of, what do we learn from this pandemic in 2022 in a modern, science-driven world? What can we leverage from this horrific experience to create far more facile methods and mechanisms and programmed ways of communicating between nations, hotspots, emerging pathogens, how that protocol, for lack of a better word, is best instituted. That takes a lot of maneuvering at a diplomatic level and at a societal level. But if we work on all these things that lead to encroachment, which is a huge, bite, or we really figure out ways of identifying where those threatening zones are, and we have, it takes international cooperation to be able to try to press those things quickly and diminish the likelihood that you lose contain, if you will, and end up with a pandemic. I don't know if you guys have other thoughts.
I would just agree that it has to be not just locally, United States, an international effort to work on this particular problem, because I don't think it's going to go away. So we definitely need to start now, trying to identify ways to, strategies to identify how we can intervene before it happens again.
For all of the disinformation and misinformation that has been out in the public about the National Institutes of Health, the Centers for Disease Control, the World Health Organization, those organizations are critical to centralize some of the work in this area. We do see things now that we didn't before. Dengue virus is in South Texas more than it used to be, likely global warming related. And Zika virus approached unexpectedly. The other things besides that are the proximity to the animals that can be the host for these diseases. For example, the avian influenza are people that are really working with poultry in mass numbers have been exposed, and there have been small outbreaks of that. I think that all of those containment issues matter. The other thing that is going to have to be addressed globally is international travel in the times of outbreaks like Ebola. And for the most part, things have been shut down as far as travel here really when it was too late. So there was travel from South Africa that was shut down when Omicron started, and it was already all over the place here. So that's going to have to be addressed, just like what you're saying, better communication about hotspots before there's already been international transmission. I think that we are all going to have to pay more attention to the NIH and the World Health Organization and the CDC going forward because of what they are going to be able to do for us.
Yeah, I think, to summarize all that, collaboration, right? If we are not all working together, we can't address the issues, we can't see where the problem is starting, and we can't move quickly to contain. So collaboration is going to be key, and I think, the organizations that are set up to kind of oversee international, nationally, that's what their role is.
Thank you for that. I am going to candidly check my phone. I see your hand, just so you're like, why is she moving? I'm checking the time. Go ahead and share your question with us, please. Can I, tell me if this is accurate? If it's possible, in a nutshell, is it possible to manage COVID outside of vaccines? Because that's what you read about in Haiti. Okay.
Yeah, so a couple of things. Number one, what we really have to consider when we see unusually low community transmission, all of our science caps need to go on in terms of reality and ask the question, are we really getting the data? Is it being reported properly? So that's one piece of very important advice. There's published evidence on this in relationship to India, which is the second most populous country in the world, but has a strikingly low rate of infections and attendant deaths as a result. And groups from around the world collaborated on investigating this and published a paper in Science very recently, just, I think, shedding some light on, on where things probably really are in that country in relationship to what's been reported. So you have to always question, and I would feel comfortable representing all of us here. Methodology is key, and who is collecting this data and how stringent are they in their methodology, and can we really count on that? So I'll hand it off to you guys.
I would say the same thing. There have been things that are unexplainable in the pandemic. Early on, there were countries that, just like this, had very little disease. And as time has gone on, some of them have had tremendous, terrible surges, India being one of them. And it's very difficult on a section of time to say that there wasn't any disease. We don't know if there was or there wasn't. There may not have been or there may have been, depending on how they're reporting and how they're collecting data. But that doesn't necessarily mean that over time they won't have the India surge or the China surge when you look at that window. I don't think the full book has been written. I think it's a really good question, though. We have wrestled with that ourselves. What's going on in these places that we're not hearing very much disease from? It's a good question.
Yeah, and I think that although there isn't published data, I can tell you a little bit that it was interesting that some places, depending on how, when the virus arrived there, was different in time. And, whenever there wasn't any testing, whenever people were getting sick, sometimes I know that I have family in Guatemala, and they would talk about how in some of the smaller towns, it was kind of like if you were sick, you stay at home, and the rest of everybody in town is making sure that people aren't coming out. So there were other ways that people were trying to mitigate the spread when in lieu of not having tests and not knowing who was sick. And so I think that sometimes having more testing available early on would have led to bigger numbers. So, there's multifactorial. So, but definitely something that will be looked at and reviewed. And I think everybody's kind of working towards that. Just kind of whenever we're looking at different time spots, where have we been, where are we going, and what are the things that we can learn about these places?
That's really it's a great question also at a purely scientific level in terms of genetics too. And so we actually are starting a collaboration with, it's a multinational effort to do some sequencing work among very specific populations around the world across a very specific group of what we call COVID-19 cytokine storm response element genes that control like the out of control inflammation that you mentioned. But we're very curious about this in our lab and in our program, and we're very excited to try to answer this and determine, are there differences mediated by where someone may come from, and could that somehow explain, perhaps, if we believe that data is not being underreported, but there are actually groups of people in this world that just are protected from COVID. I promise you, all of us in this room want to know about that, because that will change the way we approach the next challenge, globally.
Yeah.
All right, so we are technically at, are we able to do one more question? We're technically at time. Can we do one more? That's a real question.
I was just going to ask in the same vein, in the absence of data being reported, consolidated, was there any observations or patterns noticed for Australia and New Zealand?
I am not knowledgeable about this. They have had times where everything looked perfect, like what you're saying about Haiti, and then times of tremendous surges. You have to mesh together what's going on in the country and what the country is able to do to slow transmission. So if a virus is entered at a time when everything is shut down, it's a miracle they don't have any disease, but they're all locked in their homes. And there's a lot of information that you have to put together to answer those questions, but I don't have a great answer, again, as to why some areas do so well and some really don't.
I heard you when you said you didn't have the data. I was just wondering if anecdotally it
No, I don't know.
No, I think those two governments have had among the most stringent, national measures in terms of managing risk for their populations. So I probably would give a portion of the credit to their stringency and methods early in the pandemic, but Omicron kind of managed to evade even that degree of stringency. So humility there for all of us.
And I think to know that data is coming, I just came back this week from a conference for neurologists, just kind of international and national, and I can tell you that there's a lot of collaboration looking at what happened acutely with COVID, looking at long haulers, so like that, the consequences of that post-COVID and all the symptoms that are coming, and great efforts to set up these clinics that are following patients from whenever they were in the hospital to now 12 to 18 months out, and going back and looking at all these genotypes, kind of genetics, looking at what was the environment like, what was the response to vaccination. So going back to that idea of collaboration. So a lot of centers are popping up because now we need to take all this information and kind of start gathering and figuring out how to prepare, because we know that this virus is going to continue to change. And we really need to get ahead, and we really need to be ready with therapies and how can we slow it down whenever we do get to those variants that are more infective, right? That are causing higher level of disease. How can we be better prepared? And I think that across all of our societies, I would say that is the goal, is kind of working together to get this information and kind of answer all these questions. And it's not just national, it's international collaboration. And that's what we're continuing to do. So I was very happy to be there and see how many sessions were just devoted to COVID and MS, COVID and neuromuscular disease, COVID and strokes. And so it's really everybody's trying to get there, and we're trying to answer all these questions. So I feel very hopeful that all this work is getting done.
All right. Well, before we conclude, I just do want to, another round of applause for our lovely panelists. Thank you so much for sharing of your time and your wisdom to help enlighten us on what has been a very confusing time for all of us. So thank you for that. I do want to make sure to thank Theater TCU for hosting this event. I'd like to thank the School of Music for allowing us to use this wonderful space. I'd like to thank the Med School for partnering with us, and our friend from the nursing program, Dr. Glinda Daniels down there. I would also like to thank all of our faculty, our staff, our amazing students who were performing, and the list goes on and on. You know the danger of going down the thank you, oh my gosh, will I forget somebody? But thank you to everyone here within TCU who has helped to make this possible. Also our marketing, our videographers, photographers, everybody who helped to make this possible. Again, please be sure to subscribe to stethoscopestage.com. There you will see our digital program where you can learn more about the writers of our pieces and see which of our lovely cast members were performing what, and also see the full bios of our panelists as well as our script selection committee. It has been lovely, everyone, and I bid you all good night. Have a wonderful evening.